Hi, welcome to your channel Peatsway. Today we are going to discuss hypoglycemia in neonates, a very important topic and a very common in neonatal ICUs and newborn babies. So we need to understand what is hypoglycemia and what are different causes. Let's look at today's objectives. We'll first discuss what is hypoglycemia, a brief physiology, different causes in neonates, some lab investigations which can help us, and on examination some typical findings which need not be missed. And at the end we will be discussing management guidelines and discharge criteria. So if you haven't subscribed the channel, please subscribe the channel and hit the bell icon so that every video I post gets to you. So let's get started. What is hypoglycemia? So there have been a debate about the cutoff value, but latest American Endocrine Society recommends that less than 50 milligram per deciliter in any neonate, regardless of his risk factors. Regardless of his risk factor, less than 50 milligram for first 48 hours hypoglycemia. Okay, so we need to learn some basic concepts in the fetal physiology. Okay, so in fetal physiology, the first thing we need to know is that there is a linear relationship between fetus and mother regarding maternal plasma glucose, which means that the higher the mother plasma glucose, the higher the plasma glucose of the infant. Here we need to remember one thing, that plasma of the mother, plasma glucose of the mother do cross to the fetus, but insulin does not cross the placenta. This is one point we need to consider. Okay, so when high amount of glucose is transferred from the mother to the baby, the fetus produces more insulin. Okay, and insulin is a major fetal growth factor which leads to macrosomic baby. So now we know the physiology. We will be discussing the IDM baby and its implications in detail in another video. So, talking about the actions of insulin, we need to remember them because we are going to need them in further settings. So, first of all, we all know that insulin helps uptake of glucose. It deposits glucose in form of glycogen. It helps in lipogenesis and inhibits lipolysis. Okay, lipolysis is a process when there is glucose is deficient, the body switches to other fuels and lipolysis helps in this. Okay, so these are the major actions of the insulin. Now we are going to discuss that what happens, how hypoglycemia occurs, and what physiological changes are occurring in the baby. Okay, now we know that at birth, when the umbilical cord is being detached from the mother and the fetus, the glucose supply from the mother is stopped. Okay, now when the glucose supply from the mother is stopped, then the baby, newborn baby, produces increased amount of epinephrine and glucagon. These both are stress hormones. Okay, so these both stress hormones, what they do to maintain plasma glucose is they help in glycogenolysis. They break down glycogen. Okay, they break down glycogen and they suppress insulin. They have two functions. Okay, they promote glycogenolysis, breaking glycogen, providing glucose, and on the other hand, they suppress insulin. Okay, which will help in building the plasma glucose. So in low birth weight babies, we know that there are decreased glycogen stores. That's why they are at risk of hypoglycemia. While in IDM or infant of diabetic mothers, there is hyperinsulinemic state. Okay, and what this hyperinsulin does is, one, it increases the uptake into the of the glucose, posing the child at risk of hypoglycemia. And at the same time, this increased insulin delays the glucagon which is released. Okay, and this delay again risks the child to hypoglycemia. Now, in a stepwise response, how body responds to hypoglycemia. So first of all, when plasma glucose level fall below 80 milligram per deciliter, the body shuts the insulin secretion. Okay, so what does insulin secretion? How does it affect? Number one, it decreases glucose consumption. Number two, it removes the inhibitory effect on lipolysis. When insulin is low, the inhibitory effect on lipolysis is gone. Okay, so the body can shift to other fuels. Okay, now when the plasma glucose decreases further, then there are, we discussed previously, glucagon and epinephrine, which promotes glycogenolysis and lipolysis. Okay, and resulting in production of free fatty acid and ketones. We know that free fatty acids are fuel for cardiac muscles and skeletal muscles, while ketones serve as alternative fuel for brain. Okay, so when the glucose decreases further, then another stress hormone, series of stress hormone, cortisol and growth hormone are produced. Okay, and they help in building the new glucose, which is glycogenolysis. Okay, so in three steps. First, insulin secretion is shut down, and second step, glucagon and epinephrine, which break down glycogen, and at the third step, there is gluconeogenesis. So, what are the symptoms of a baby with hypoglycemia? The child can be asymptomatic. Okay, however, there can be symptoms such as abnormal cry, decreased feeding, lethargy, jitteriness, irritability, hypothermia, apnea, pallor, cyanosis, sears. Okay, the important concept to remember is that treat hypoglycemia even in absence of symptoms. This is very important because hypoglycemia in neonatal age has neurodevelopmental outcomes if not treated. So, coming to the etiology, very important to know the etiology of hypoglycemia so that when a child comes to us with hypoglycemia, we are able to differentiate different causes and we can help, and this can help us in further management. Okay, so regarding the etiology, we divide it in two causes: transient transient hypoglycemia and permanent hypoglycemia. Regarding transient hypoglycemia, we again divide into two. Number one, which are endocrine based, and number two, non endocrine based. In endocrine based, we mainly have infant of diabetic mother and hyperinsulinemic states. Okay, and hyperinsulinemic states can be like there is stress hypoglycemia in cases of birth asphyxia, in cases of preeclampsia, and cases of small for gestational age. Okay, so these stress hypoglycemia produces hyperinsulinism. This can be transient and this can be permanent. We will again discuss here it can be permanent. So in transient hypoglycemia, we have endocrine causes including infant of diabetic mother and hyperinsulinemia. While in non-endocrine causes, we have prematurity, delayed feeding, increased IUGR, sepsis, maternal use of beta blockers. Very important, we often miss this, and polycythemia. So all these factors predispose the child transiently to hypoglycemia for 24 to 48 hours. Now, coming to the permanent causes of hypoglycemia, we have endocrine causes, okay, in which we have very important hyperinsulinemias, growth hormone deficiency, hypocortisolism, and panhypopituitarism. Okay, other endocrine cause is again hyperinsulinism. Okay, now this hyperinsulinism we have discussed, it can be transient and it can be permanent. Transient, like in perinatal stress, asphyxia, small for gestation age, IUGR, preeclampsia. But sometimes this transient hyperinsulinemia can be prolonged more than 48 hours, so we have placed in the cause of permanent as well. Okay, now other major cause of hyperinsulinism, permanent cause, is different genetic causes which uh, are affecting the receptor levels and insulin secretion, the different genetic conditions. Okay, so regarding endocrine, we have two conditions. Okay, one is hyperinsulinemias and hypocortisolism, panhypopituitarism. Other causes include inborn error metabolisms like galactosemias, glycogen storage disease, fatty acid oxidation defect, and organic aciduриas, and none the least, hepatic dysfunction. Okay, so now we are clear that we have a set of causes we have to choose from. Either it's transient or it's permanent. In transient, either it's endocrine, non-endocrine. Permanent, it's endocrine, non-endocrine. Okay, so now we have list of causes and we are quite confident to pick up hypoglycemia. So on examination, there are few things which needs to be remembered. Like if the child is large for gestation age, we know that child will be having increased insulin exposure, which lead to hyperinsulinemia and causing the child to at risk of hypoglycemia. The child with small for gestation age, these are the findings we will look for examination. We know that they have perinatal stress and they have decreased glycogen stores. Okay, which place the child at risk of hypoglycemia. Now, midline defects are very important. Okay, like encephalocele, other midline defect. Then we will be looking for panhypopituitarism if the child has midline defects. Okay, now we will also look for syndromic features, especially macrosomia and macrocephaly. We have two syndromes associated with hypoglycemia, which is Sotos syndrome and Beckwith-Wiedemann syndrome. Now, Sotos syndrome has gigantism and macrocrania, large head and large body, while in Beckwith-Wiedemann we have hemihypertrophy. While half body is hypertrophied, there is macroglosia. Sometimes there is associated umbilical hernia and hypoglycemia. Okay. Now another very important cause, if you find a child with nystagmus with hypoglycemia, okay, you should rule out septoptic dysplasia, which is again a cause of hypopituitarism. Now, coming to the lab investigation, whenever a child with hypoglycemia we are encountered, okay, we need to do critical sampling. Now, what is critical sampling? Critical sampling is when the child is hypoglycemic, we take blood samples and we run some tests regarding electrolytes, bicarbonate, and insulin level, beta hydroxybutyrate, free fatty acids, cortisol, growth hormone, and lactate. Now, these critical sampling helps us in differentiating different causes. Okay. Now, if we find in our investigations that child has increased insulin, decreased beta hydroxybutyrate, and decreased fatty acids, okay, we will do ammonia levels. If there is normal ammonia level, it means it is either perinatal stress or genetic cause of hyperinsulinism. Okay, while if the ammonia level is raised, then we have a condition called GLUD1 mutation. Now, in another case, if we have decreased insulin, Okay, and there are increased free fatty acids. Okay, increase free fatty acid, which mean that free fatty acids are not being metabolized. We have fatty acid oxidation defect, okay, which present with hypoglycemia. We have long chain, medium chain fatty acid oxidation defects. Now in third scenario, if we have decreased insulin and we have increased beta hydroxyrate and increased free fatty acids, okay, we will do lactate levels. Okay, now if the lactate is normal, we have endocrine causes like panhypopituitarism, isolated growth hormone deficiency, and adrenal insufficiency. While if the lactate is raised, then we have organic acidemias, glycogen storage disorders, or disorders of gluconeogenesis. Regarding management, if we encounter a child with hypoglycemia, first of all, we try to establish the enteral feeding. Okay, but if the hypoglycemia is still persistent, apart from enteral feeding, then we need to increase the frequency of feeding, and we can increase the caloric density or we can use the fortified formulas. Okay, well, if the child is hypoglycemic, the emergency management, we have to give 2 milligram per kg bolus of 2 ml per kg of 10% dextrose water. Okay, now in term infant, there is 4 to 6 milligram per kg per minute glucose infusion rate, while in preterm this is increased to 6 to 8 milligram per kg per minute. Okay, while the infants with hyperinsulinemia require more than 15 milligram per kg per minute. Okay, more than 15 milligram per kg per minute glucose infusion. So this is hyperinsulinemia. Okay, now we have discussed enteral feeding, we have discussed IV dextrose, then we have some pharmacological options. Okay, in pharmacological options we have diazoxide, and this is the only drug which is approved for hyperinsulinemia. Okay, it is given in a dose of 5 to 10 mg per kg in 3 divided doses. However, it has a side effect of fluid retention and pulmonary hypertension, and these side effects are counterbalanced with use of a thiazide diuretic chlorothiazide. Okay. Now, if the hypoglycemia is still persistent despite using diazoxide, we use another drug, octreotide. Okay, and this is in the calcium channel inhibitor, and it inhibits the release of insulin. However, this drug places the child at risk of necrotizing enterocolitis. Apart from these, we have glucagon, glucocorticoid, and growth hormone deficiency according to specific cause. At the end, coming to discharge criteria, this is very important that if we have a child with hypoglycemia, we need to have safety in fast. Okay, so what is safety fast? This is fasting of 6 to 8 hours with close monitoring. Okay, the child is placed at a fast of 6 to 8 hours, and after that plasma glucose is measured. The plasma glucose should be more than 60 milligram per kg, should be more than, sorry, 60 milligram per deciliter. Okay, or more than 70 milligram if any medication has begun or suspected permanent etiology. So discharge criteria is safety fast. If it's not possible, at least preprandial plasma glucose should be more than 60 milligram per deciliter, and preprandial glucose should be more than 70 milligram if persistent hypoglycemic disorder is suspected. Okay, so more than 60 milligram per deciliter in normal neonate, and more than 70 milligram per deciliter if permanent disorder of a permanent cause of hypoglycemia is suspected, or any medication has been used. So that's all for today. I hope you liked this video and it helped you in understanding the physiology and different aspects of hypoglycemia. Kindly like the video, share the video, and do subscribe. That's all for today. See you in another video.